Good afternoon and welcome to the Assembly Committee on Health and Human Services. Secretary, will you please call roll?
Dahlia. Here. Edgeworth. Here. Gonzalez. Goulding. Here. Gray. Here. Hafen. Hibbets. Here. Hunt. Here. Jackson. Here. Koenig. Nadim. Wynn. Here. Orentlicker. Here. Chair Brown-May.
Thank you, I am here. Would you please mark our members in and present when they arrive, as they are in and out and heading to a number of other bill hearings today, so we should have members joining us later. Okay, so I would start with a couple of housekeeping items as we begin today. So I want to welcome our audience here in Carson City, those who are joining us in Las Vegas, and then anyone who is joining us online. As a reminder, please silence your electronic devices while we are here today. If you wish to testify, please sign in at the table by the door and provide a business card. When testifying, make sure to turn on your microphone and clearly state and spell your name. Members of the public may provide testimony on a bill either in person or by telephone. To do so, you would call 888-475-4499 and provide the meeting ID when prompted, which is 843-0813-7645, and then press pound. Meeting agenda and committee information is available on Nellis, which can be accessed through the legislature's website. You can also join or watch our meetings through Nellis or the legislature's YouTube channel. Public comment today will be taken at the end of our meeting, and each person will be limited to 2 minutes. As a reminder, we expect courtesy and respect in all of our interactions for this meeting. Please note that committee members will be using their laptops or other electronic devices. It's not a sign of disrespect. They are monitoring all of their materials online. We have 2 items on our agenda today. First is an overview of public health in Nevada, and we are welcoming with us the Division of Public and Behavioral Health Deputy Administrator of Community Health Services, Julia Peak. And thank you for joining us today. You are welcome to begin when you're ready. Thank you.
Good morning, Chair and members of the committee. On behalf of our public health community, we want to thank you for allowing us the opportunity to present today. My name is Julia Peak, and I serve as one of our deputy administrators for the Division of Public and Behavioral Health. And I'm joined by many of my colleagues in the room behind me, and they helped prepare these slides and are ready to answer questions, or if you wanted to hear about what they're doing locally, they would love that opportunity. But before I jump into the slides, I have one very special guest that I wanted to introduce. Her name is Ileana, who's sitting behind me. She's 6 years old and is a first grader at Bohatch Elementary School and wants to work in government like her amazing mom, who's also sitting behind me, who plays such a huge role in our public health infrastructure and improvement program. So thank you for letting me introduce her. Okay, jumping in, the scope of public health is often really hard for us to describe. What we look at as a field is really what makes people sick and what makes people die, so morbidity and mortality. We develop and implement strategies to address these things, hopefully upstream, as you'll hear us say as well. We increase and promote things that make people healthier. It's extremely broad and flexible. There are some foundational public health services that I'll talk about in a little bit, but we do need to pivot often to address whatever's making, again, our community sick or dying. Very little is codified for public health in Nevada law. Much of it is standards or foundational responsibilities that are through like our public health accreditation program. That's one thing that all of us are pursuing here in Nevada, and that really sets our standards. Public health is a system that often works in the background, so you don't necessarily see us or know what we're working on unless something breaks. You don't see the diseases we prevent. You don't necessarily assume we're working in the background when your food is safe, your water is safe, etc. So when I say public health system, it truly is a system, and I apologize that this is small, but it can speak to really how many folks are involved in this system. We certainly do have people who study public health and are public health professionals, but in order to intervene, to make people the healthiest, live the longest life possible, it takes so many. And on this slide, you'll see just a few of our partners, truly not comprehensive, but we often work with our laboratory partners, coroners, social services, transportation, elected officials like yourself, and our tribal partners, just to name a few. This really also provides context as it relates to social determinants of health. So when we're working with our partners in the community to address public health, it's often targeting some sort of social determinant, and many factors have to occur in order to move the needle on a health outcome. So what is public health? Often, when people ask me, what do you do for a living? And I say public health, they say, you're a nurse. I'm not a nurse. Most of us aren't nurses, but we do hire nurses. So we don't provide necessarily what's called clinical services. We do in certain situations, and we work very closely with our clinical partners, but public health is a focus on population. Population or subpopulations. If there are certain groups that are being affected in some way that's different, we look at how we can intervene and work with that specific group, but not the individual per se, the population or groups of people. We often look at how we reduce disease, chronic conditions in the entire community, and like I said, we have a much broader scope. Often we get confused, like I said, with clinical services, but a different field of study. So foundational public health services. This is what our Public Health Accreditation Board has defined as services that we should be providing as a minimum package. And as you look through these, I'm not going to read them to you, but you'll see that behavioral health, which is something all of our local partners are working on, as is the state, is not a foundational public health service. Maybe it will be one day, but it is a priority in addition to those that FAB is what it's called, the Public Health Accreditation Board has put in place. And so some of the things we look at are communicable and infectious diseases. That is often what you see if public health is identified publicly. There's a foodborne outbreak that'll make the news. COVID, obviously, H5N1. So it tends to be the infectious diseases that you see most often in public health. But we do a great deal of work looking at systems that affect like maternal and child health, family health, linkages to care. Again, not necessarily providing the care directly, but those linkages. Also, some foundational capabilities that are really, really important to us. We are a very, very data-heavy field of work. So we collect a lot of data for infectious disease, a lot of surveys of our population, and I'll speak about a few when I talk about our university partners. And we look at health equity, who's being affected, and then why they're being affected in a certain way. Policy development is one of the things we work in alignment with you all on, trying to understand if there is a policy option that could improve the health of Nevadans in this case. And we have a lot of accountability and performance management standards, primarily around the public health accreditation, but we certainly had that prior as well. So I think this is a really important slide and helps contextualize the work that we do. Individual health is really done at the clinical care level. So again, a huge part of what we look at in public health, but we look at much larger levels of intervention, and you all come in at the policy level. CDC noted the greatest public health achievements. They noted 10, vaccination, motor vehicle safety, and I want to highlight motor vehicle safety because I think it really highlights the work that can be done at a policy level. So that intervention, or interventions, I should say, looked at how we reduce injuries and death related to motor vehicle incidents. And we've made huge strides in public health with the various partners looking at this, having to look at child safety seats, seatbelt laws. Those have all made astronomical changes in traffic safety. I also serve on the Nevada Traffic Safety Advisory Committee, as does the chair, so that one is near and dear to my heart. So public health agencies in Nevada. So we're only one of 2 states, us and Texas, that have what's considered a largely decentralized structure. Most of the work done in public health is done by my partners in the audience and their organizations. But Nevada Division of Public and Behavioral Health has a unique role in that we are the safety net health authority in the counties that don't have a district or an authority, and so we often provide services in our frontier counties. You'll see that done through our community health nursing program, environmental health program, and similar programs. So we're very much a hybrid of service delivery in the state. So as I mentioned, our state public health agency is the Division of Public and Behavioral Health. We are considered like a super mega agency because we have public health and behavioral and mental health all under the same umbrella. That's atypical. But has had some successes because we were really able to work closely with our behavioral health partners in substance use prevention, opioid issues. So the public health community and the more traditional behavioral health community has really done well under this structure. So our local public health agencies joined with us today. We have Carson City Health and Human Services, Southern Nevada Health District, Northern Nevada Public Health. You might know them as Washoe County Health District because they had a name change, and the Central Nevada Health District. As I mentioned, we don't have a ton codified about public health within our statutes, but we do have some standards. And so Chapter 439 is the best place to look to understand our public health structure and basic requirements. That really outlines our state board of health and our chief medical officer, who have specific roles about oversight of infectious disease, public health responsibilities, et cetera. We also, within that statute, have county boards of health and county health officers. Right now, we're fully staffed up with health officers except for one county, and they are working on getting one. We also have a section on health district and district health officers, city boards of health, that applies to Carson. And then during the Great Recession, we used to have some general funds coming to the division that would help support TB and STD, could pay for direct services. That was removed during the Great Recession, and this assessment became part of statute. And so the counties in which we provide service, specifically for nursing, epidemiology, and environmental health services, they pay us an assessment, and then we do that on their behalf. Each county is required to have a board of health, appoint a health officer. As I said, we have all but one active and ready. And they also have a subset of requirements, again, not the foundational public health services. It's really related to infectious disease. And they may have some additional requirements, but not a whole lot is noted for a county board of health or a county health officer. One of the things that we've been seeing, which has been a great way to mature our public health services, is having services start to be provided more locally. As I said earlier, Washoe County Health District, Northern Nevada Public Health, again, same entity, and Southern Nevada Health District have been in place for a long time. So they've been providing those services for our urban counties for quite a long time. One of the things that we're trying to do in Nevada is regionalize our frontier counties to have them start offering services locally. If they want to start providing services, they have to request that from the governor, request to have that fee removed, put together a plan to say that they're competent to provide those services. They go to the governor, and then they go to IFC. And if that is approved, then they start offering those services locally. Central Nevada Health District is the newest to do this. Carson City Health and Human Services does, as well as Douglas County and a few other counties. As I mentioned, regionalization would be a great win for our state if we were able to get all those services offered locally. This is no small feat. And so Central Nevada Health District can speak to this probably the best because they're going through it and have gone through it. But we're really trying to encourage counties to look at this. They could also offer services locally for their county in and of itself, but that's a challenge for our frontier counties because they're so small and they wouldn't have really the infrastructure funding to set that program up and or to find the workforce needed to sustain that. So I talked a little bit about the health districts. I'm going to focus right now on Central Nevada Health District because they're our newest. So they formed officially December 3rd, 2022, and they're a partnership between Churchill, Mineral, Pershing, Eureka, and the city of Fallon. And so they got together with like-minded counties actually during COVID and after COVID and said, we think we could do this locally. And we said, absolutely, let's figure out how we do this. And so they weren't necessarily adjacent counties. Eureka doesn't touch the other three counties. However, they were like-minded and all wanted to move down that same path. So that's a huge win for public health. Carson City Health and Human Services, though not a health district, they do provide excellent services in the Quad County region. For those of you that live in this area, I'm sure you've seen the great work that they do. So 2 types of health districts are further codified in statute, and that's based on population size, which is not atypical in our statutes. I do want to take a minute and acknowledge the work that was done with SB 118. $15 million was given to each county through a per capita allocation to work on public health services, and we can't thank you enough for doing that. The second part of that bill was removing the word adjacent, as I noted, and that's really, really important if counties want to regionalize but don't necessarily want to regionalize with the county right next to them. It really has to do with the foundational beliefs that counties have and how they want to develop public health, and so they might not necessarily be right next to each other, but you all allow them now the opportunity to work across counties within Nevada to develop these districts. So some of the infrastructure challenges that we face is we're often the convener and not the doer, and that's for a variety of reasons. We don't have huge staffing, but we're sometimes not the subject matter expert, or we're not the one that can make the change in that population. So we're often the one that gets groups of people together, as was shown in that illustration with the wheel. We do need flexible funding. Again, thank you for giving us the money last session. The governor has put that into his base budget, so we're very hopeful that that could be a continued source of funding. But without a flexible funding, we're really, really challenged to address the needs of the counties as they come up. We are largely dependent on federal funding. The larger counties are about 50-50. For us at the state, many of our programs are entirely federally funded. So if there's any changes to that, we would no longer operate that program. And that's difficult, and also many of those are categorical. So it says you will do this very specific thing that we've directed in this way. And that doesn't allow us often the latitude to make changes if there's a different need or we want to try it slightly differently. As I mentioned, a decentralized system is challenging. In a single county, you may have 2 to 3 different public health agencies supporting you in whatever that condition may be. We also have huge fiduciary responsibilities at the state, especially during COVID. We had more money flow through public health probably over the course of the year than the entire century prior. And so that was a lot for us, and the state does provide that fiduciary responsibility to get that money out to our local partners. We are becoming much more data modernized, I'll say. That's important priority for the federal government, but also for us. Prior to COVID, we were getting infectious disease reports through a fax machine. And when COVID hit, our fax machines caught on fire, basically. And our community partners couldn't get those faxes through to us. They were trying on the clinical side, understanding how busy they are. And so we've made great advances in that area, but it's very expensive. But our federal partners are supporting those efforts right now. I'm going to transition a little bit and talk about our health districts. As I mentioned, Southern Nevada Health District is the largest health district in the state. They also operate a federally qualified health center. This is very unique to them. They have had many successes over the biennium, and I want to acknowledge the good work that they noted here in the areas of behavioral health. As I mentioned, not a foundational public health service, but a need of our communities. They also developed the Credible Mind Community Dashboard and the clinic, as I noted on here. In that same vein, they've been working with naloxone access. We've all been working really hard on this, but they've had such innovative ways to distribute this to the community. They've been nationally recognized. They're recognized by our state. They also, I've been with this state for 18 years. I started with the STD program, and congenital syphilis was present when I started on my first day and still is. But the work that Southern Nevada Health District is doing is so incredible and really technical assistance for the rest of the state. If we could scope those to be statewide, that would be incredible because congenital syphilis is not going away. Last but not least, I wanted to acknowledge their wastewater surveillance. This is something new that we really started seeing in public health during COVID, and it's really innovative. We need to figure out what this looks like long-term and how it can be used with our other surveillance systems, but certainly something Southern Nevada Health District and the state has jumped on board with. We also wanted to talk about challenges. And so the biggest challenge they noted, you'll hear it across the board, so spoiler alert on that, is sustainable and non-categorical funding, which you all came forward and helped us with. We often have to change course. Again, with COVID, there's infectious diseases that pop up routinely, H5N1. That's a unique response. If we don't have funding that's flexible, we know it's here, and we have staff that are categorically funded, and it's really difficult to address those things. We're also going back to pre-pandemic funding levels at the federal government, and so that's a challenge too, because Nevada has really always been understaffed in public health, and we're going to remain that way. Also, just the political environment with public health is yet to be determined, so we're all on pins and needles for that. Carson City Health and Human Services, they wanted to highlight the great work that they've done with the SB 118 funds. I'll also note they were a beta testing site for the Public Health Accreditation Board nationally. So they're such an incredible public health agency in this state and have been a leader in that regard. When we do public health accreditation, we have to look at the data and we have to develop interventions to address that. That's how we measure our successes or figure out how we're going to pivot to do better. And so what they noticed locally was substance use prevention and recovery, access to basic needs, access to healthcare for specific populations, and mental and emotional health. They used their SB 118 funds to work with proven partners in the community on these topics to not only spend the funds appropriately, but also implement quickly because we only had the biennium to spend that allocation. Challenges, again, categorical funding. Super thankful for the categorical funding that the federal government gives us, but it doesn't allow us the flexibility we need often. The CDC did respond to that issue with non-categorical funding after COVID, and so they've developed some infrastructure grants that have helped us fill those gaps. But again, unclear if that will continue at the federal government level. As I mentioned earlier, the two larger health districts are about 50-50 federal funded, so if we lost federal funding, all of it, we would lose 50% of the staff. Carson City Health and Human Services, Central Nevada Health District, us, we have a different infrastructure where Carson is at 75% federal funding, so they would almost entirely be eliminated should federal funding cease. They also have, like I said, done great work in their needs assessment, but if we don't have funding to address what's found, it's really just data collection and no intervention, which is really tough for all of us. Workforce remains a challenge for all of us. We have two accredited schools of public health. I'll talk about them later. And so we have the opportunity to get a ton of public health professionals, but that's not the entire agency. As I mentioned, huge fiduciary responsibilities. So recruiting people with financial management skills and business degrees and administrative assistants. We need all of them to make the public health system work. So some successes, reaccreditation, which is huge for the health district. They also are continuing to work on their needs assessment. They have focused their public health infrastructure grant on hiring a public health communications specialist. One of the things that we have found during the needs assessment and also some great work that our partners at NACO did doing town halls is that we offer a service in a community, but people don't know it's there. So for the sake of argument, it doesn't exist for them. So much of that is pushing out the information, and Carson focused their public health infrastructure grant on that. And as I mentioned, the SB 118s have been a huge success for them. So Northern Nevada Public Health, Washoe County area, they have had great successes and changes over the biennium, and I just want to acknowledge their former health officer, Kevin Dick, who did wonderful, and their new health officer, Dr. Chad Kingsley. He and Nikki Aker, who's overseeing Carson City Health and Human Services, they're in Washington, D.C. this week, educating the folks there. So they apologize for not being here, but they're a huge asset. Dr. Kingsley is also reestablishing the State Association of County and City Health Officials. We call that a SACHO. That will really give the voice to the counties as they work with the state. As we talk about policy and funding challenges, that'll be the mechanism in which we use. So huge thank you to him for doing that. So what they note as challenges is similar to what you've already heard. Funding cuts are a huge uncertainty. And the workload is so incredibly great for all of us that when we don't have the sustainable funding, it's really hard. We also have a boom and bust cycle with public health, and I think the illustration here that Dr. Kingsley provided is really huge. Our expenses go up, but the grant funds, especially at the federal level, stay equal. So if we give people raises, then we give people raises and services decline. And so unless we have the opportunity to have the funding increase with the rest of the world, then we're really challenged to offer just the same services. So even if the grants level, we actually are offering reduced services. They did want to highlight some outcomes as a result of the funding, and that's noted on the slide as well. We have very little epidemiologists in the state related to per capita recommendations, and so that's really a challenge. We're not able to investigate all of the things that we would like to investigate. We have to prioritize those. Environmental health, the clinic, vector control, that's one that is greatly underfunded in the state, but I know on everybody's radar when it comes to be mosquito season. Very little we can do for mosquito abatement. And then administration. As I mentioned, Central Nevada Health District is the newest. Funding for them is so incredibly important because as they find staff and hire staff, if they can't sustain, that's really hard. They also have a huge challenge as it relates to workforce because as you can imagine, their workforce is not large. So you have one person potentially doing an entire service for the state. If you lose that person, either because you've lost funding or because they got another job offer, you fail to offer that entire service to your community. And so we've been working closely with them to figure out how we sustain that, how we recruit. Can they get assignees to help them with that? As you'll see here, again, access to mental and behavioral health services, wraparound services, access to care all remain a huge issue in the Central Nevada Health District region. Transportation services are one of the hardest things in our rural communities, so that again is something that affects all of us, but our rural and frontier counties the most. So workforce development, to transition a little bit, nationally the public health workforce needs to increase by about 80%. Ours is probably worse in Nevada. As I said, we're tend to underfund this area. About 20 or 30% have formal public health training. Our university partners have really stepped up with ARPA funding approved by this body to develop workforce growth, career development for staff already on site at local and state health departments. 30% of the workforce is considering leaving the field for various reasons. Public health has had a lot of burnout. There also may be other reasons that they're choosing to leave, but we have to backfill them. 2 of the schools in Nevada, UNLV and UNR are both CEF accredited, and that's huge for us. We are putting out really skilled public health professionals and working really hard this last biennium to develop a clean pipeline to get them into state or local government. Public health professionals can do a variety of things once they get their degree, and we're really trying to ensure that they come and work for one of us if at all possible. UNR School of Public Health wanted to highlight a few things. They have a humongous undergrad group. They also have graduate and PhD. They do have an online program as well that's been really huge for working professionals. Kinesiology is one of the things that they're really known for, and I want to acknowledge UNR for the good work they're doing and hearing what the community needs. We're greatly challenged in getting environmental health specialists, and so those are the folks that go into restaurants or address foodborne illnesses in the community, and it's hard to find folks who will qualify, and so they're working on getting a curriculum that would get folks right out of school and into our program. So want to acknowledge and thank them for that. They also do great work with CASAT. I'm sure you've heard them in the behavioral health area, and then with our dementia-friendly work as well. They also, as I mentioned, received ARPA funding, and they have provided scholarships to our staff. Several of our staff are getting PhDs, and they would not have otherwise. That's huge for us to be able to upskill that staff. We have folks who got an associate degree, never thought of getting a bachelor's degree, and are now able, with that ARPA funding, to get a bachelor's degree and work their way up in government. That's incredible, and again, a thank you to you all for approving that funding. UNR often functions as our bona fide agent for certain federal grants, and so for the Behavioral Health Risk Surveillance Survey and the Youth Risk Behavior Survey, they're our bona fide agent, and so that's the data that's collecting information on our youth at middle school and high school, and then also the population 18 and older. Ton of data, very, very hard to fund. So one of the things that they noted they would like to work on is sustainable funding for those surveys. That would be huge for us. It's a core way to collect data. I also want to acknowledge that we're working with all the universities on developing academic health departments. The local health authorities are also doing this. Great way to improve pipelines, but it also allows us to work with incredible researchers at the university to take academics and research and apply it to practice in Nevada. So we're super excited about that, and a lot of work has been done in the biennium to establish those things. And it's not just public health, as I mentioned, trying to get folks from the communication field, IT, business schools, journalism, to come and work for government. So the UNLV School of Public Health, they were the first CEF accredited school in Nevada. They have a couple programs that I want to acknowledge. Healthcare administration, that's the degree that I got, and I think it's a great opportunity for folks interested in going into government. Gives you the healthcare administration skill set, and they also have an EMHA for the folks that are already in the field. They too have a PhD. They have been such a huge asset to us in infectious disease response. I just want to acknowledge them for that. This next slide really speaks to that as well. They are developing they developed a parasitology and vector laboratory, which is huge to help the public health practice as we look at those types of infections. Ongoing need, They are hugely dependent on federal funds as well. So we push federal funds out to them. When they lose those, they lose programs. That affects students, that affects faculty, and the sustainability for them. They also do a lot with getting private donors and then applying for grants for healthcare workforce as well, as noted on here. My last slide. Kind of unrelated but related. So our Office of Analytics has done a phenomenal job putting our data together so you could look at what it looks like for your specific district. So if you're wondering how do I do with immunizations in my district, infectious disease, death rates, etc., I highly encourage you to look at this. We have ranked it so you can see how you rank in the state, but that's a great way to say how is my population in my jurisdiction doing, and we continually update that for you to review. With that, we are ready to take questions.
Thank you for that presentation. So as we begin, I would like to start with the we, if you don't mind, so that our members know who the we are. So first I will ask, if you are a state employee working in public and behavioral health, would you please stand up if you can so our members know who you are? Thank you. I appreciate that. If you are with one of the public health districts and you are working to support this division, so a member of our community working in public and behavioral health, and you are here to be a part of this presentation, would you please stand up if you are able? Thank you. I'd like to say thank you all for all of the hard work that you do, and recognize our special guest here today, Miss Ileana, who in first grade will be the future of our state. So I appreciate that you're all here and the hard work that you do to support all of our citizens every day in all of the areas that we have just touched upon. With that, I'd like to go to members. We do have questions. We'll start with Assembly Member Ohrenlichter.
Thank you, Chair. Thank you for the presentation and the important work you do. One of the things you mentioned is the uncertainty at the federal level, and it's unclear what's going to happen with the Centers for Disease Control. You also talked about regionalization within the state to take advantage of economies of scale and all. Is there also opportunities, regionalization at the state level, that with our neighbors that can help us meet the challenges with the federal uncertainty, and after all, a lot of these public health challenges cross borders?
Julia Pete, for the record, through you, Chair, great question. So first, the uncertainty at the federal level, we are just waiting for the dust to settle to see what happens there. We think some programs might end, but we're hopeful that that will not be a lot. But we are trying to figure out what that looks like for our state. We're going to continue to operate all our services until we're told otherwise. So tons of opportunity for regionalization within the state, opportunities to partner with other states. There is great opportunity and collaboration among states. We're part of a lot of associations that work amongst states so that none of us are recreating the wheel. We also have great opportunity and have a lot of public health professionals that move in from other states and have known programs that work, have colleagues in other states. There's already systems embedded within the public health infrastructure where we work very closely with the other states. We have something, for example, called the Interstate Communication of Confidential Records. So if people move, as they do, we share that information with other public health agencies so we can best offer the support. We also, as a state that's hugely reliant on tourism, we often have people that come here, maybe get tested here and are found to be positive for something. We work with the state to figure out how we work with them to get care. As far as do we partner or regionalize with other states, I can't think of an example, but my colleagues might. But there's a ton of collaboration that's really embedded within the infrastructure. But I don't know if anybody has anything to add on that.
You're welcome. If anyone has anything to add, you are welcome to take the table. There's not a lot of movement there. No, right? Like run. Okay. Thank you. Do you have a question? Assemblymember Edgeworth.
Thank you. Thank you for everything you're doing. This is This is my jam. I love this. This is great. So I have a question, hopefully not too much in the weeds. Prior to the pandemic, there were vaccine programs that enabled people without access to medical care to get vaccines. And that was VFC, so Vaccines for Children, which of course hasn't been touched. And then there was also a 317 is what they used to call it, 317 vaccines. And during the pandemic, I completely understand that everything shifted towards COVID vaccinations. But my question is, are you getting back to pre-pandemic vaccinations? And there was an initiative about Hep A just right before COVID. Now we don't remember that. And then definitely influenza. We're seeing really high numbers right now. So I can be more specific about the populations or the programs, but I'm curious to know if you're kind of getting back to pre-pandemic vaccinations.
Yeah, Julia Peak for the record, through you, Chair. Great questions. And so the locals do offer many of these services, so they could come to the table and talk to this. I'll highlight a few. So we do still have VFC and 317 operating. You all also provide us funding for cocooning, is what it's called, cocooning. And so we're very thankful for the G Fund you invest in that. That we use to cocoon a baby when they can't be vaccinated. So you provide funding for us to immunize the family members to keep that child safe. We continue to work on outreach for vaccination. We had gap funding for a short period of time to fund COVID if the person didn't have the ability to pay. But those kind of programs are phasing out, if not entirely phased out. I think the last one ended this past year. So it primarily is working with either our partner organizations to offer the vaccination at a reduced cost, or we've done in the frontier counties something unique. If we do it as a point of dispensing exercise, a pod, then we're able to exercise our public health preparedness, offer the free vaccine because we're testing to see if we could offer mass vaccination should it need to occur. So we try to be thoughtful in the funds that we do have to offer reduced or low-cost vaccinations, but many of those programs that you mentioned, VFC 317 or core, we do not think those will be touched if there's changes at the federal level, but again, to be determined.
Thank you. The cocoon is just the Tdap, right? Probably, but
Julia, sorry. There's one more. I think we might have done COVID, but I can confirm.
So not counting COVID vaccines, let's just say that that's a whole separate situation. My question was, there were programs for influenza, for example, for people who don't have access, don't have money. They're expensive vaccines, and if for the sake of public health, have we gotten back to the levels of, let's just say, flu vaccinations?
Julia Peak, for the record, are you asking if we're offering those for free? Or what are the levels of
My
vaccination?
question is, I'm so sorry, it's in the weeds, so I won't ask again, but pre-pandemic, we were offering through 317 free vaccines, which was largely flu. It was some others as well. My question is, now that the pandemic and COVID isn't as much, I've been told that the state, I don't even know who that is, decides if 317 vaccines can be utilized to vaccinate people who don't have access to vaccines.
Julia Peak, for the record, I'll check with our vaccination program because I don't want to give you misinformation unless the locals have more information than I do.
Thank you.
Thank you. Deputy Administrator Peak, while you're doing that, would you identify if there are pockets of our population that are unvaccinated? That would just be good to know as well. And now we'll move over to Assemblymember Goulding.
Thank you. Thank you for your presentation and the important work that you do. I'm wondering, as a state, have we learned lessons from the pandemic that we are able to, that your team is able to apply to better prepare us for the next pandemic?
Julia Peak, for the record, through you, Chair, great question. Yes, so much. Some that come, we've done after action reports that I could provide to you as well that just debrief every part of the response and lessons learned and how we'll do better and different next time. Some of the things I would like to highlight that have changed our ability to respond, at least for this generation, is the collaboration made across agencies. Our ability to work with our partners at National Guard, DEM, that is so quick now. Because we've exercised it so much. Also, I want to acknowledge the work with Department of Agriculture, the ability to pull in groups of people that maybe don't work together, develop a structure to get PPE out. That was something we had to look at very quickly with H5N1 in addition to COVID. Well, we've done it. We did it with COVID and we know how to make that requests locally come to us. We know how to operationalize getting specimens transported throughout the state. That was very chaotic during COVID. We have somebody in a frontier county. How do we get that specimen to the lab to see if it's COVID or not? We've worked through a lot of those issues, so I hope we're much better prepared to quickly operationalize all the work with our partners. But there's so many nuanced things that we learned, develop plans ahead of time, develop those relationships ahead of time. Those are really ingrained in our response now, so I'm incredibly thankful for that. Data and being able to utilize data quickly. As I mentioned, we were operating in fax machines in the beginning. So when we were getting questions about how many cases you have, we're going as fast as we can, and there was delays, and the numbers were changing because we'd get a fax that wasn't able to come through or the data wasn't fully prepared yet. So modernizing our data system so we can act more appropriately and timely is a huge win that came out of COVID. So a lot has been learned that I hope makes us more prepared. The challenge is the funding. So, for example, we had to teach a ton of people how to do disease investigation when COVID hit. They weren't epidemiologists or disease investigators. We worked with college students to learn that trade. We worked at private sector employees to learn the trade and do that investigation. Those folks have all been released. The funding is not there. So if we had to scale up to the level of COVID again, we would have to again, train people. We've done it. We know how to do it better. But there's not people waiting in the wings to support if we had another pandemic. So the funding remains a challenge for us.
Next, we have Assemblymember Koenig.
Thank you, Chair. So I was Churchill County Commissioner when we put together the Central Nevada Health District, and so I think that was one of the best things I probably did as commissioner, actually. But my question is I remember, and this is more not specific because I can't remember specifics, but I know that that process was pretty arduous, that there was lots and lots of things that we had to do. And if you went back and showed me the specifics, maybe every single one of those things needed to be done exactly the way it was done. But if is there any possible way to maybe streamline that process or make that a little bit easier so that we potentially could get some other rural health districts without, like I said, when they came with me all the specifics, I might not have paid all the way attention. So I can't tell you we shouldn't need to do this or we shouldn't need to do this. But is there any possible way to potentially make that maybe a little bit an easier process to help facilitate maybe some other rural health districts?
Julia Peak, for the record, thank you for helping with that. I remember you during the process and your support. Central Nevada Health District taught us so much about the challenges and the hoops. They have written a toolkit to help other counties do it. So the work that they did in real time has really made a difference. I'll also say I think one of the best things that we did during COVID is fund a public health professional, she's in the audience as well, at the Nevada Association of Counties. Huge, incredible investment, who's working with county leadership to figure out if this works for them, talk about that very difficult road ahead of them if they choose to do it, but also talk about the wins and the huge opportunity for local government. As I mentioned earlier, if anyone wants to become a health district, it takes the county commissioners supporting that. So in addition to NACO, the toolkit that Central Nevada Health District put together, that's helped a lot. There are probably more things we can streamline to make it a bit easier. But I think the challenge for Central Nevada Health District is they were learning in real time. There were some things we didn't even know they had to do that we learned by not doing it and then trying to go back and do it. So those kinks have been worked out, I hope. But at the very least, you have NACO, you have us, and you have Central Nevada Health District who did it successfully to help those counties.
Thank you. Next, we have Vice Chair Nguyen.
Thank you, Chair. And before I want to go into my question, I just want to compliment our special guest. I mean, at 6 years old, she's amazing at sitting still. I mean, that is skill sets that some of our colleagues don't even have. So this is amazing. So thank you for being such an awesome guest today. So in terms of the public health space, I know there's a lot of work that you're all doing, and I just have the biggest form of respect to all of you in your work. As you know, I've worked with you in some of my former hats. If we can address a little bit on the language access piece, and I know public health space, language access is very critical in terms of, Nevada is such a large, diverse populations. We have folks from all over the world. I mean, we have an entertainment industry that has, a lot of folks from all over the world. Do you see any challenges with the language access implementation in terms of all these funding cuts? And then, of course, if you can highlight some of your collaborations effort with the community partners, perhaps, and that even if some of these federal resources go away, that we still be able to, serve our public.
Julia Peak, for the record, excellent questions, Vice Chair, and I think that the local partners will have some thoughts on this. I'll start with the language access plan piece. Again, thank you all for approving some funding to implement that. It was great in concept, and we wanted to do it, but we're so reliant on federal funds that we did need to request that general fund. And so with that general fund, we're going to be able to translate everything all our vital documents, all of the resources that our community needs to access programs into Spanish. After that, we'll figure out then what other languages we can incorporate. We were able to embed the phone system so that I'll just say for H5N1, a good majority of the population that we're serving who were potentially exposed are Spanish speaking primarily. And so we've had to utilize the language line to ensure that we're communicating effectively with them, their risk, and then checking in with them on symptoms. So having that in place because of the language access plan discussions last biennium was extremely helpful in allowing us to ensure that we could communicate effectively with them. I think the biggest challenge there is just ongoing funding as we change things within the system to be able to either work with a vendor to change it. In the past, we were hugely reliant on using our own state employees who weren't getting compensated for that. They happened to be bilingual. We asked them to translate things. So having the funding to actually work with a vendor to help us, I think, is the ongoing need there. I'll also note during COVID, we had grants specifically for diversity and equity. Those have since ended, but some of our partners chose to use their SB 118 funds or their public health infrastructure grant funds to continue to fund those folks. So diversity and equity coordinators, we hired a tribal liaison who that's their job 100% of the time. We never had the opportunity for that. So we're trying to incorporate positions that can dedicate their time and or have funds to dedicate that resource if we need it. So good work was done this biennium, but certainly more to come.
Thank you. Deputy Administrator Peak, I have one question, if you don't mind. I'm curious to know, we talked about the number of health districts that are across our state and really great presentation. So thank you for the clarity that you've provided here. Is there a number one health priority that each one of those health districts would focus on if they could focus on that? And while I don't expect you to have an answer for that today, right, for policy perspectives, right, given that we are here in session at this time, how do we as legislators then help to champion the primary issues that are happening in each of our regions?
Julia Peak, for the record, and I would love the others to talk, but on behalf of the group, we've worked a lot on this for many, many years, and our priority, and you hear it all the time, is just non-categorical funding. And I'm sorry to come to you with our handout in that way, but we have to pivot so much. H5N1, again, primarily affecting our frontier counties. We have to be very thoughtful about language access. We have to be very thoughtful about PPE. There could be something with vector-borne. As I said, we have almost no funding for vector-borne. So if something were impacting our mosquitoes that were impacting our humans, we would not be able to address that timely. So when we have non-categorical funding, we can pivot that. If we were working on an IT project that would have helped streamline data to make it actionable, and there's an issue with vector control, we will pull that money and transition to the priority for our community. We just don't have that opportunity with the federal funds. So that general fund allocation of non-categorical is our backbone. So I think all of us would say that would be our priority because we don't know what's around the corner.
Thank you. Members, any other questions? As we close out today, I'm wondering if Ms. Ileana will join us at the table. Thank you. When we met at the beginning of our meeting this morning, I'm over here. Thank you. When we met this morning, well, this afternoon, you said that there was a wish you had for our community, and that's why you were here today. I'm wondering if you would share that with our members.
People are happy and healthy.
Nailed it. Nailed it.
Thank you so much for sharing that. Would you state your name for the record and spell your name for our secretaries?
Ilyana, Ilyana.
Thank you, Miss Ileana. Thank you so much for the presentation. Thank you for sharing your story with us today. Okay, thank you so much for being here and for the presentation. We're going to move into the next item on our agenda. I will now open the hearing on Assembly Bill 234, which requires Medicaid coverage for screening for certain forms of cancer, and welcome up to the table Assembly Member Anderson and her team. You may begin whenever you are ready.
Good afternoon, Chair Brown May, Vice Chair Nguyen, and members of the Health and Human Services Committee. Thank you for scheduling this hearing today, although I think it's going to be very difficult to follow up Ileana's wishes. What a great way, though, to be introduced, because I do believe the bill that I'm presenting today will help in that way, I hope. My name is Natha Anderson, and it is my honor to represent Assembly District 30. I am joined today by Carrie Harrington, Carihrington, who's the Executive Director of the Nevada Cancer Coalition. As stated on the American Medical Association's information published Friday, February 21st of 2025, so just a few days ago, cancer is a word that can stop us in our tracks. Stirs up a whirlwind of emotions. But in the fight against cancer, knowledge is more than power. It is a lifeline. In that same way, so is early detection. The earlier we find out, the better. But just a few more stats. According to the American Cancer Society, it is estimated that more than 17,000 Nevadans will be diagnosed, and more than 5,000 Nevadans will die of cancer in 2025. Screening can help prevent this risk of death from breast, cervical, colorectal, lung, and prostate cancer by detecting cancer early when treatment is more successful. The intent of AB 234 is to protect access to cancer screenings for Nevada Medicaid beneficiaries and increase access to all evidence-based colorectal cancer screening options to improve screening rates, decrease late-stage cancer detection, and ultimately save lives. Nevada is one of 6 states which currently does not provide the coverage of DNA stool testing for colorectal cancer. Nevada Medicaid currently provides payment for the cost of breast, cervical, colorectal, lung, and prostate cancer screenings in accordance with the Patient Protection and Affordable Care Act, or ACA. However, only breast and cervical screenings are clearly stated in our state laws. Thus, the proposed bill language aligns NRS both with ACA and current Nevada Medicaid practice to include and protect coverage for lung, prostate, and colorectal cancer screenings. With the Chair's permission, before walking the committee through the bill, may I hand it over to Director Harrington to discuss the importance of access and the at-home testing options for colorectal cancer, especially for our rural, frontier, and working families of Nevada.
Yes, thank you. Please go ahead.
Good afternoon, Chair Brown, members of the committee. For the record, my name is Carrie Harrington. As you heard, I'm the director with Nevada Cancer Coalition. And really, this bill is about equitable access to care for our most vulnerable. As you heard, first, protecting access to life-saving cancer screenings for our Medicaid recipients. And secondly, improving equitable access to all screening options to find cancers earlier when they're easier to treat. And we're talking specifically about colorectal cancer for this component. So FDA-approved evidence-based at-home screening options for colorectal cancer screening has really been an incredible advancement in increasing access to care. So we all know colonoscopy has been the gold standard, but fecal immunochemical testing, FIT tests, I'm sure you've heard of, and the newer, with better adherence, it is the multi-target stool DNA test. You might have heard of Cologuard. That is the newer test. It has better adherence, and it's every 3 years versus every year, which is required of FIT. So for our rural and frontier populations, communities that might have few, if any, colonoscopy providers, all these options are critical for them to have access to. For the working parent who isn't afforded time off work to go for a colonoscopy, this could be their only option. Here in Nevada, 99% of our non-Medicaid insured have access to all of these testing options. Our Medicaid recipients do not. I wanted to say thank you to you all for hearing this today. Huge thank you to Assemblywoman Anderson for bringing this bill forward, and a thank you to Nevada Medicaid, who's been working with us on this as well. Thank you.
Assemblymember Anderson, just if I may walk you through the bill, although it's not lengthy, I want to make sure everybody understands what's happening. In Section 1, Subsection 1 of the bill, it would amend Chapter 422A, adding screenings for lung cancer and prostate cancer into the statute for Medicaid coverage, and B, adding colorectal. You can tell I have a speech impediment, so I've got to practice this a lot. Cancer screenings and all available colorectal cancer evidence-based methods of screening for Medicaid coverage. Subsection 2 directs the Department of Health and Human Services to, if necessary, obtain a waiver of federal law or to apply for an amendment to the state plan for Medicaid to receive federal funding to fully provide coverage for lung, prostate, and colorectal cancer screenings. There is a conceptual amendment to address the typo that is in the current law language. It simply expands the title all the way out to colorectal. I believe there are a few patient stories which have been uploaded to Nellis. However, I would like to end with this. I've been putting off getting a colonoscopy for several years until last fall. I did, and while it wasn't the most fun thing I've ever done, it was so very easy and much more comfortable than scheduling a colonoscopy doing the prep, taking the day off to get it done. My results came back with no worries, thankfully, and I actually had some weight lifted off my shoulders without that worry any longer. I made a promise to my friend Matt that I would get screened. He passed away from colon cancer, and he was my age. I honestly felt guilt not scheduling the colonoscopy every time I thought about Matt. That is not from me. That is from one of the stories that was uploaded to Nellis. Thank you again, Chair Brown-May, for this opportunity, and we are more than happy to take any questions you may have.
Thank you for your presentation. I just have one clarification for members. We have this amendment that is with us in the bill. That is the amendment that you're referring to. Okay.
Assemblymember Anderson, for the record, that is correct.
Thank you. With that, we do have questions. We'll begin with Assemblymember Ohrenlichter.
Thank you, Chair, and thank you for bringing this very important bill. My question has to do with the difference between the way you've worded the requirement for lung and prostate cancer and colorectal cancer. So on line 4, page 1, it says screening for lung cancer and prostate cancer. And on line 5, evidence-based methods. So I'm curious, and with lung cancer, there are all kinds of things you can do to screen. Is that going to be decided by HHS? Is that somewhere else that they have authority to figure out which screening, or is that decided by the federal government? How does that play out?
For the record, Carrie Harrington, through you, Chair.
You may go direct.
Very good question. So this is decided the United States Preventative Task Forces. They are, they're a panel with the U.S. government. They're the ones who really decide what screening options are approved and evidence-based. They do all the research, and the USPSTF, for short, USPSTF, they are the ones who make those decisions. All insurers are required to provide those screening options, as are Medicaid and Medicare. So for lung cancer right now, it's low-dose CT. We typically don't have to spell them out. In this case, we needed to, which is why it's on a separate line listed the way you see it. Thank you.
Thank you, Assemblymember Edgeworth.
Thank you so much for talking about cancer and cancer prevention, such an important topic. I was going to ask the same thing Dr. Ornlicker asked about why one is evidence-based and why the other is just kind of willy-nilly. And I think everybody thinks that early detection is a great idea. I think everybody believes that we should know if we have cancer. The tragedy with cancer is that not every cancer's screening actually leads to a decrease in mortality or decrease in morbidity. And lung cancer, as you pointed out, is one. It's a very tiny fraction of people who would be eligible by the USPSTF for lung cancer. And then as it happens with prostate cancer, I'm not an expert in a stretch of the imagination, but my understanding is that there isn't an actual required by USPSTF prostate cancer screening. There's a lot of debate, and the Association of Urology wants this thing, and AAFP, and everybody has their own recommendations. But are you saying that they would be adhering to USPSTF? Because there isn't currently, my recollection is, a screening that is highly recommended by them for prostate cancer, for example.
For the record, Carrie Harrington, thank you for the question. That is a very good question. And prostate, they do have a recommendation for USPSTF. Currently, Nevada Medicaid covers it, as do most insurance companies cover it as well. So Medicaid is currently covering all these screenings. They're just not all listed in statute. So they're currently covering prostate. It's just not listed in statute. There is a recommendation for it through USPSTF. It's not necessarily a required screening. I know it's very strange, but they are already covering it, and insurers cover it as well. There are a number of different screenings for prostate cancer, and I might defer to one of the docs who might be here as well today to talk more about prostate.
And Assemblymember Anderson, for the record, I really appreciate the question, Dr. Assemblymember Edgeworth. Greatly appreciate the question, because I think from somebody that is not in the medical field and reads the articles when preparing for something, or when somebody's come back with information, I think what we're trying to do more than anything else is trying to get the statute to match the practice at this time. So your question is so accurate that, well, what is the test that you're using? That's more something that I think that's not necessarily part of statute, more part of either regs or possibly even part of other discussions that the department would be having with the national ways of doing so. But I really appreciate the question, because it's raising awareness, which is what we're trying to do with this language as well.
Thank you. Thank you for addressing that. I wasn't as much asking about the test, although I would love to talk about tests, love to talk about that. I'm not talking about the tests that are required, and recommendations change all the time. I'm more talking about if you don't have evidence-based lung cancer, could not some sliver of people say, well, I decided to do a chest x-ray on every single person. I just feel like maybe it needs to be limited to whose recommendation, not the test itself necessarily. I could see how, without using evidence-based, how it could go a little crazy.
If I may, Assemblymember Anderson, for the record, through the chair to Assemblymember Edgeworth. Thank you for that clarification. I think that's one that I would need to talk a little bit more with, that we would both need to talk a little bit more with the department itself. Make sure that that's a little bit clearer, either in the statute or in the regs, whichever one it might be. But really appreciate you bringing up that awareness, because it's a very important statement to make. It shouldn't just be somebody that's got like, hey, I feel like it should be this way. We should make it very clear as to what those expectations are. Thank you.
Thank you. Next question we have from Assemblymember Nadeem.
Thank you, Madam Chair, and thank you so much for bringing this bill forward. It's very important. My question is, do you have the data, how many lives can be saved with early detection if the Medicaid approves this, and the people will be getting early screening for rectal, for screening of the colorectal cancer, lung cancer, prostate cancer? Do you have the data for that?
Assemblymember Anderson, for the record, through the chair to Assemblymember Nadeem. Thank you. I didn't even think of to ask for that, and it would make sense to have that sort of evidence-based information. So I will ask for it and try to get it back to you right away.
Okay, thank you.
And I'll make sure that it goes to everybody on the committee, because it's an excellent question to ask. Thank you for bringing that up.
Thank you. Next question we have from Assemblymember Koenig.
Thank you, Chair. Important. I think it's good legislation. I know this isn't a money committee. We do have a ballpark on what this would cost.
Assemblymember Anderson, for the record, through the chair to Assemblymember Koenig. No. There's been, I'm just going to be as candid as possible. No, there has, however, been discussion with the department since August of a year ago about doing this. And so this is not something new. I noticed that there was nothing when I looked at it this morning. I don't know in the last few hours if there's been added anything, but there has been no fiscal note that has been explained to us at this time. There has, however, been ongoing discussions regarding it.
Thank you. Members, any other questions? No additional questions. So thank you for your presentation. At this time, we'll ask you to step back from the table, and we will look for anyone in support of Assembly Bill 234. If you are here in support of Assembly Bill 234, please step forward, take the table. You have 2 minutes, and you may begin when you're ready.
Thank you. Thank you. My name is James Cohen. I'm testifying as an individual, but I am on the board of Nevada Cancer Coalition, and I'm on the policy committee of Nevada Oncology Society, but they don't have a clue what I'm going to say today. So I'm a recently retired medical oncologist. I've been doing this for 53 years. Before I start, I want to agree with Assemblywoman Edgeworth that prostate is still controversial. And I want to thank Assemblyman Koenig because he introduced what I'm going to talk about. So I'm just going to give a personal anecdote. About 2.5 years ago, I looked in the mirror and I saw an obvious malignant melanoma on my abdomen. So I had the biopsy, the wide excision, the lymph nodes, some radiology procedures, and the cost came to somewhere between $20,000 and $25,000. So if my tumor had been 2 millimeters thicker, that's 0.08 inches, the standard of care would be a year of immunotherapy. So last week I asked the oncology pharmacist at Renown, what would a year of immunotherapy cost for someone my size? And it came out to $702,000 for the drugs. That doesn't include doctor's visits or lab tests or treatment of adverse reactions. And if the melanoma were more extensive, you don't stop at a year, you continue immunotherapy indefinitely until I reach 101, in which case I'd probably stop. And you can extrapolate that to all the 5 diseases that we're talking about where there's evidence-based screening, that early diagnosis is pretty cheap and easy to treat and often curable. And if it's advanced, all the patients end up with either chemotherapy or immunotherapy or a combination of both. So I don't know the data on how much it costs to screen the people, but you save a lot of money shifting the curve to the left and diagnosing it early. And that's not even to think of the other economic toxicity of metastatic disease, which is job loss, loss of time from work from caregivers and things like that.
Thank you so much. You're at 2 minutes. If you'll wrap up, that would be
I
great.
am done at 2 minutes. Thank you.
Thank you so much.
Good morning, or good afternoon, Chair, members of the committee. Allison Herzik, Herzik, Director of Nevada Government Relations for Dignity Health St. Rose Dominican, and we are in support. Thank you.
Good afternoon, Madam Chair, committee members. Todd Inglesby, President of Professional Firefighters Nevada. We wholeheartedly support this. Cancer is a leading cause of death in the fire service because of the carcinogens we're exposed to, our firefighting gear. We as a state PFN organization, along with the International Association of Firefighters, have been studying and doing pre-screenings through conventions and programs throughout the United States. And with that said, we are finding we're saving lives, we're saving healthcare costs, and we're keeping our members actively and employed and on the job. Thank you.
Good afternoon, Chair Brown, main members of the committee. My name is Aurelie Alarcon with Career Nevada on behalf of Comprehensive Cancer Centers of Nevada, and we submitted a letter of support of this bill, and we appreciate your consideration. Thank you.
Good afternoon, Madam Chair, members of the committee. Sasha Stevenson, for the record, here with Nevada Oncology Society, and we are in support of anything that effectively increases access to screenings for these kinds of diseases.
Good afternoon, Madam Chair and members of the committee. My name is Sarah Adler with Silver State Government Relations, and we are proud to represent the Nevada Advanced Practice Nurses Association. So our advanced practice nurses work alongside oncologists to provide cancer treatment, yet NAPNA's mission is to increase access to health care, the more so when it is preventative health care. So they are in full support of this bill, and although fortunately the screenings discussed are already practice, clarity and reminders coming through NRS is not a bad idea. So thank you.
Dear Chair Brownway and members of the committee, my name is Eric Jang, ERICJNG. I'm the Executive Director for One API in Nevada. We're a nonprofit organizing advocating for the fast-growing Asian Pacific Islander communities here in Nevada. And we're currently doing a report to disaggregate data for our community. In compiling existing research, we do find that for health equity from 2010 to 2019, a whopping 48% increase in breast cancer cases among the AA and HPI community here in Nevada. It follows the national trend for a 52% increase for AAPI women under 50 from 2000 through 2021. So we believe the screening part and detection is very important for our communities, hence we support this bill. Thank you.
Good afternoon. For the record, I'm John Packham, John Packham. My day job is with the University of Nevada, Reno School of Medicine, but today I'm here on behalf of the Nevada Public Health Association, which stands in strong support of AB 234, which would, again, expand access to cancer screening for Nevada Medicaid beneficiaries. We are in full support of any measure, evidence-based, that reduces the burden of cancer and chronic disease that is disproportionately borne by rural, low-income, and medically underserved populations. We also stand in support of efforts, whether they are apparent or not, that safeguard and fulfill and implement the Patient Protection and Affordable Care Act, which has been under siege, honestly, since it was passed nearly 15 years ago. Again, NPHA stands in support of this measure. Thank you.
Thank you. Is there anyone else here in Carson City here in support of Assembly Bill 234? Seeing no one, I see no one in Las Vegas. IVH, is there anyone on the telephone line in support of Assembly Bill 234?
If you would like to testify in support of Assembly Bill 234, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 157. Please press star 6 to unmute your phone. You may begin.
Good afternoon, Chair Brown-May, Vice Chair Nguyen, and members of the Assembly Health and Human Services Committee. My name is Jacqueline Nguyen, Nguyen, and I represent the Nevada State Medical Association, the oldest and largest organization representing physicians in our state. We'd like to thank Assemblymember Anderson for bringing forth this bill. NSMA recognizes the importance of preventative screenings, and we appreciate any efforts that help reduce cancer morbidity and mortality. Therefore, we are fully supportive of AB 234. Thank you.
Chair, the public line is open and working. There are no other callers to testify in support at this time.
Thank you. At this time, we'll move into opposition. Is there anyone here in opposition of Assembly Bill 234? Please come forward. In Carson City? Seeing no one in Las Vegas. AVH, is there anyone on the telephone line in opposition of Assembly Bill 234?
There are no callers at this time.
Thank you, AVH. At this time, we'll move into neutral testimony. Is there anyone here in neutral on Assembly Bill 234? Please come forward at this time. Seeing none. Seeing no one in Las Vegas. Again, we'll move to AVH. Is there anyone on the phone lines, AVH in neutral for Assembly Bill 234?
There are no callers at this time.
Thank you, AVH. Assemblymember Anderson, would you like to make closing comments?
Assemblymember Anderson, for the record, again, I just want to thank you, and I'm more than happy to have further conversations as you see fit. Thank you so much for this opportunity.
Thank you, and we will officially close the hearing on Assembly Bill 234 at this time. That leads us to our last order of business on our agenda today, which is public comment. As a reminder, each person has 2 minutes to provide testimony. Public comment may be submitted to the committee up to 24 hours after a hearing. Anyone here, and thank you for taking the table to offer public comment. Please reminder you have 2 minutes. Please state and spell your name for the record. You may begin when you're ready.
Thank you. I'm Dr. Colleen Lyons, Lyons, and I appreciate the opportunity to speak on the behalf of primary care and the importance of primary care in the state of Nevada. I'm a fourth-generation native Renoite, currently reside in Carson City. While I happen to be the Carson City Health Officer, which is a contract position, I'm only speaking about the importance of primary care. I got my training with the military. I practiced in solo practice here in Carson City for some 19 years and then practiced with the VA for 5. And without a doubt, one of the biggest reasons why we have the kind of problem that we have with medicine in America is we don't have enough primary care providers. While Nevada has tried to solve that with nurse practitioners, most of those have found themselves in the cities and not necessarily in the rurals. And personally, I have some concerns there about having your primary care through a nurse practitioner, especially if you have any problems that are outside the realm of sort of bread and butter. So anything that comes before you of a health concern or a medical concern or even mental health, be sure to incorporate the opinions of your primary care providers. Those are family physicians, pediatricians, and internists. And be careful on incorporating specialist opinions because they can be self-serving. And the more specialists you have per capita, the higher the cost of providing care and the poorer the outcomes. The more primary care physicians and primary care access you have, the better the outcomes and the lower the cost. So be careful who you listen to. Thank you.
Thank you. Is there anyone else here in Carson City who would like to offer public comment at this time? Seeing no one in Las Vegas. AVH, is there anyone on the phone lines for public comment at this time?
Public line is open and working. There are no callers at this time.
Thank you, AVH. That concludes our business for today. Members, as a reminder, our next meeting is on Wednesday of this week. We will meet at 4 o'clock in the afternoon in room 4100, where we will hear presentations from the Division of Health and Human Services, as well as several other interested parties. And so I look forward to seeing you on Wednesday. With that, we are adjourned.